Good evening and welcome to the penultimate meeting of the Republican Labour Education Forum's series in the run-up to the general election. This meeting is dedicated to health and social care. We're just about to launch our manifesto, which outlines our vision for a Commonwealth of England. We're using the word Commonwealth in its original meaning, where the wealth of a country is held in common by all the people of that country. The clause on health and social care in that manifesto reads as follows. The Commonwealth will provide a fully comprehensive, publicly owned health and social care system from cradle to grave. Health and social care will be free for all citizens and funded from general taxation. Its management will be organised on democratic principles, with management boards containing representatives of the workforce, patients, and other stakeholders. I'd now like to introduce our first speaker, Dr. Bob Gill. Dr. Bob Gill is a GP and he's been a health campaigner for many years now. I'm sure many of you will have seen him on the Not the Andrew Marr Show. He also produced a documentary called The Great NHS Heist. So I'd like to hand over now to Dr. Bob Gill to lead off our discussions this evening.
Thank you. Thank you very much, Carol. So what I've been tasked to do is just to give a brief summary in terms of the state of the NHS now and how we got here and what needs to happen to restore it. So we've had a 40-year transition from a publicly funded and publicly provided universal comprehensive system to what now essentially resembles the American managed care model, receiving public funding, but largely corporate controlled and increasingly corporate provided. In order to pull this off, we've had to be lied to by consecutive governments, and successive legal changes have been presented with innocent phraseology such as reform and modernization. But what has actually taken place is a root and branch restructure. And perhaps we could start back in the 80s, with 1983, with the Griffiths reforms, essentially gutting the slimline management within hospitals and within health authorities, often led by senior clinicians and a very small administrative staff. Well, that was replaced, and you had a burgeoning of senior management and administrators who were being brought in to use the ways of the market to bring this hypothetical market efficiency within the NHS. What they didn't tell us was actually before they did this, the NHS efficiency was world renowned. It had an overhead of about 4%. And by the mid-2000s, it had estimated to have grown to 14%. So a 10% increase in administration and overhead was their definition of efficiency. So we swallowed all of these plausible narratives. So the Griffiths report and reforms then was followed by the creation of an internal market by Ken Clarke, which was this phony exchange of funds between primary and secondary care. GPs would be able to somehow mystically exert influence over the hospitals to improve performance. But of course, it was a way of establishing market thinking and terminology and, a normalization of the concept of a market within healthcare. And then we had the Labour government stepping in, promising to undo the Thatcher reforms, but in fact reinforce the market, 97 to 2010. In 2000, for the first time ever, privatizing clinical services. The private sector was going to help out because of their good nature with waiting lists. Interestingly, Wes Streeting is using the same line once again, and he's blatantly calling for more private sector provision. But Blair and Brown got away with suggesting this was a temporary arrangement whilst the NHS got on its feet. But it never did, because all the way along, using the Labour Private Finance Initiative scheme, there was a consecutive shrinking of NHS capacity and provision. Now, if you have a big public service, it crowds out the private sector. So the governments have had to squeeze the public sector so the private sector can expand. The private sector cannot compete with a strong public sector in a natural monopoly such as healthcare. So they shrunk bed capacity, saddled the NHS with PFI debt, borrowing 11 billion. We're going to pay back over 80 billion, at the end of which we don't own any assets. So you have an asset transfer that has taken place. And then we had the Lib Dem coalition where Cameron came along, initially promising no more top-down reorganisations, and then instigating the Health and Social Care Act 2012, which was written by McKinsey's management consultants who have been heavily involved in NHS privatisation. And what this did was formally convert the fake internal market into a compulsory external market. And they sneaked this extension in by using a statutory instrument which followed on the later in 2013, called Section 75, which made tendering compulsory. So then you had GPs hypothetically in charge of streamlining services. We had an austerity program following on from the banking crash. We saw 10 billion, the Nicholson challenge, I believe it was 10 to 12 billion. And you had a decade of defunding of the NHS. So it never kept up with its historical rises in budget, which averaged about 4%. The decade 2010 to 2020, the average was around 1%. We did have a slight deviation to pay for the catastrophic response to the pandemic, where we had corruption, scandalous PPE purchasing, paying through the nose for a vaccine of limited value, and lots of more dodgy deals went on, including PPE that was totally unsuitable and all the rest of it. So we had a bonanza of profiteering and outsourcing, and a pandemic response led by an accountancy firm, Deloitte's, and the outsourcing giant Serco. So having learnt nothing that in the preceding year dismantling public health was not a good idea, selling off public health labs was not a good idea, and giving mass redundancies to all the public health professionals was also not a good idea. So we had a politically driven, transnational driven pandemic response, which was an utter failure, as was the conclusion of the Public Accounts Committee. They estimated the 37 billion did nothing to slow the spread of the pandemic or impact it in any way. So this was an utter disaster for the public purse, but very profitable if you were closely connected to government. And what the pandemic also provided cover for was the next radical and perhaps final legislative change, which was in July 2022, another Health and Social Care Act. But what this did was created new public-private entities, public-private partnerships called integrated care systems, which essentially create structures looking after 2 to 3 million people, and they were going to be handed over a tax-funded budget with which they could do as they please. And now the door is open for profiteering, essentially by keeping staff wages suppressed, importing a de-skilled, less qualified staff workforce. You could describe it as a scab workforce, actually, to undermine the existing workforce. And also money was to be made through the denial of care. And this could be done on a system-wide basis, where you might decide for one ICS, we no longer provide fertility services for anyone who's under their care, or on an individual basis, whereby your medical records could be scrutinized and an algorithm decides whether they see fit in terms of you surviving or benefiting from an operation. So we have a movement afoot which essentially removes the clinicians out of the decision making and puts it down to a computer or a group of administrators to decide what's in your best interest. So the utter inverse of open and democratic accountability, we now have a closed doors, secretive, bureaucratic arrangement whereby the public have very little influence or scrutiny in terms of what's taking place with their taxation and in their name. So we now have an arrangement whereby the government has abandoned control of health service provision, yet the common narrative is about funding. There's this bit of an arms race, who's going to maybe fund the NHS a bit better. But as I've described, we do not have an NHS which is channeling money efficiently to the front line and service provision. We have now a endemically dysfunctional NHS, which is wasting billions servicing PFI debt, paying for the bloated bureaucracy, which must be costing the NHS in excess of 20% of its budget. And if the American system is any guide, they spend 36% of their healthcare budget, which is twice the size of ours, on administration and profits going to the insurance industry predominantly. So in the from 2014 to 2019, who did we have as head of the NHS to see these final reforms through, which were actually in place before the legislation? We had a man called Simon Stevens, who we employed, headhunted from United Health, America's biggest private insurer. United Health presence in the UK is predominantly through their subsidiary Optum, and their presence has become even more dominant. They now own EMIS, which is the GP patient record system, electronic record system, controlling over half the GP patient data in England. They've also bought up a prescription software called Script Switch, another platform involved with training called 14 Fish. So this insurance company now has significant capture of data relating to the workforce and relating to patients. They are heavily embedded within NHS management, senior management, board level within these ICSs, and they're responsible for training the legion of administrators and managers who are going to inflict this dystopian system upon us. Now, what has gathered belatedly some public attention is this program of doctor substitution, using variously titled people, including physicians' associates, which have made the headlines because earlier this year, the GMC said, we will regulate these people. Now, let's not forget the GMC was formed to prevent quackery, to prevent people presenting themselves as doctors who weren't doctors from practicing on patients. Well, now the GMC has introduced and given cover to this breed of non-doctors who might have 2 years of medical training, don't have to pass an exam, have no clear scope of practice under their umbrella. And that helps create confusion amongst the public. It creates a perception perhaps of greater skill than they really have. At the same time as introducing this parallel workforce, the government is actively restricting training for doctors. So for nearly every speciality, there are more applicants for the speciality post than there are vacancies. Now, for general practice, for a doctor who's been to medical school, completed 2 years within hospital rotation, now having done 7 years of medical training and experience, they only have 3 years left before they can be a GP if they get onto a training scheme. But for every place on a training scheme, there are 3 applicants. We do not have a problem of lack of doctors. We have a problem of lack of training for doctors and a lack of jobs for doctors when they finish that training. So now we have a situation where there are actually a growing number of GPs who are unemployed. And there are more and more delayed diagnoses, misdiagnoses, and preventable deaths at the hand of this inexperienced substitute workforce, which is being normalized in the public eye. So there has been some pushback, but I just want to read you something from the Institute of Economic Affairs, a blog they published in 2012, How to Abolish the NHS. And this paragraph states quite clearly what the governments have actually achieved without ever spelling it out to the public. Here it goes. Perhaps most importantly, the compulsory licensing of medical professionals should be abolished. Anyone should be at liberty to practice as a doctor or nurse, with patients relying on brand names or competing voluntary associations to ensure quality. Ending current restrictive practices is essential to enable private firms to increase productivity in the sector. Now, if that is not shocking enough for you, what the governments have actually done is to avoid drawing attention to the situation. They've not deregulated the professionals, they've just incorporated the non-doctors into the GMC to create the same effect without the negative headlines. And, you know, the idea of having a medical system without people reaching a certain level of qualification or experience, you don't have to be a genius to work out this is hugely potentially dangerous for patients and also traumatizing for the staff who have to deal with the fallout. The pushback I mentioned earlier, there is a group of anaesthetists who've got together to launch a legal action against the GMC. The BMA have belatedly stepped up, although their legal action is very narrow. They're not arguing that the GMC shouldn't regulate these people. They're arguing on how they should be regulated, whether they need a separate body and a clearly defined scope of practice. Well, in my eyes, the BMA is in fact giving a green light for a workforce that is not necessary if you employ and train and provide opportunities for the doctors we have. So this is a problem the government has created, and it's introducing a predetermined solution to get through what the IEA phrased abolishing the NHS back in 2012. So that's a summary of where we've got to, and what does this mean for patients and the workforce? Well, it's a nightmare getting access. If you're unlucky enough to need emergency care, you're going to be in an overstretched, overburdened, understaffed A&E waiting for hours. If you want to see a doctor face-to-face, this is getting increasingly difficult. In fact, the goal is to block access to seeing a doctor because the non-doctors will be providing non-triage first port of call assessment, despite having huge clinical blind spots. So access to basic primary care is being removed. Access to secondary care is being removed. One way of removing access is to have a lengthening waiting list. We have approaching 8 million on the waiting list now. You close down A&Es, you shut down capacity, and ultimately you destroy public and professional confidence in the system such that people are softened up for all the advertising we're getting on TV now for taking out top-up private insurance. Now, top-up private insurance is a whole subject in itself, but essentially this is a money-making scheme, and the money is made by accepting your premiums when you're relatively fit and well, paying out when you're relatively cheap and inexpensive, and then pricing you out of cover when you become expensive and seriously ill. And it will be at that point that the middle classes who thought they were safe and opted out will realize that actually now they're reliant on what's left of the NHS because they can't afford their premiums. So what has been inflicted upon us without any democratic mandate and essentially a media blackout or a diversion on very fixed and narrow talking points, such as funding, we are in a situation where our politicians have totally betrayed the public, they've betrayed the professionals, and they've acted on the interests of transnational corporations and big capital interests to really undermine and sell out what is in the best interest of the nation, which is a healthy population, which can be contributing economically and to their family. But instead, we're going to have more and more people with unmet need, disability, and preventable pain and suffering, which is a huge tragedy given the lessons of the NHS was how successful it had been until the Thatcher era, whereby they decided they no longer needed to live up to the post-war settlement and organize a system to redistribute wealth to the richest. Thank you.
Thank you very much indeed, Dr. Gill. You've painted a chilling picture of the future of healthcare in this country. We'll take questions and answers when our other speakers have talked, have given their contributions. So I'm going to go now. I'm going to go now to Ian Spencer, who is a mental health nurse, to give his contribution. Over to you, Ian.
Good evening, comrades. It's really a reflection of what's already been said, but with specific reference to mental health services. In particular, I want to look at the decline in the nature of the services, the decline in overall satisfaction, mental ill health being effectively dealt with by the wrong people, and the de-skilling of staff. So just as there is a parallel with the scenario set out by Dr. Gill, you're also now getting nursing associates and a higher proportion of care being given by wholly untrained staff. In 1968, 90% of nursing was done by nurses or nurses in training, and a higher proportion is now done effectively by carers, what would have been called auxiliary nurses, nursing assistants, now healthcare assistants or whatever. A variety of different titles are available. The other aspect of it is increasingly there are private providers who are effectively providing the NHS service, and they're not doing it for nothing. And finally, I want to just mention something about the availability of psychotherapy and the nature of the psychotherapy that's available. So in terms of, if one looks at a recent report by the Nuffield Trust, so there's been a decline in a significant effect of the COVID pandemic on people's mental health. What we got during the pandemic, of course, was mental health referrals really dropped significantly. Since then, they've been rising continually. Part of it is a bounce back from people who were not treated properly during the pandemic itself, but a lot of it is also as a result of problems associated with changes in society as a result of the pandemic. If we look at things like referrals, we're seeing an increase in the number of referrals overall for psychotherapy, an increase in referrals for mental health services in general. However, 1 in 3 of those referred for mental health, in particular talking therapies, so they didn't actually see anyone for long enough for it to make a difference. So what you tend to get, in order to increase the sort of the reported figures for the number of people receiving psychotherapy, you get a limited range of, for example, cognitive behavioral therapy sessions. So you might get 6 sessions, and after that, you're on your own, or you buy your own, or try and look for some other provision, or rely entirely upon pharmaceutical interventions. So typically, the prescription of antidepressants, anxiolytics, and so on. Generally speaking, in the mild to moderate range, psychotherapy is as effective, if not more so, than antidepressants. Even in the severe range, moderate to severe range, where antidepressant medication is of help, it is more helpful if they can receive psychotherapy as well as pharmaceutical interventions. But the availability of that psychological intervention isn't there. So in a CQC report in 2023, October 2023, something like 40% of mental health providers were rated as inadequate or required improvement or inadequate, just on the basis of safety alone. Gaps in community care are effectively putting a strain on hospital care. And one of the things that we're seeing really is in the absence of proper psychiatric facilities, people are forced to go to A&E. Just as we saw with the closure of psychiatric hospitals, and the psychiatric hospitals, had their drawbacks, their problems, their critics, but we at least provided a service. So what I now see, for example, is instead of people having treatment for drug and alcohol withdrawal in a psychiatric hospital, which used to be a common feature, what you now see is that that's thrown onto the general hospital, that's thrown onto A&E. Similarly, if people are actively psychotic, instead of being admitted possibly on a informal basis to a psychiatric hospital, they are instead thrown onto the tender mercies of waiting for hours in A&E until such time as the crisis team or whoever else who acts as the gateway to psychiatric services can turn up and see them. And often during that time, people deteriorate. Another feature that we see is with the decline of mental health inpatient facilities. I'm talking about here in absolute numbers. There's been a decline every year since 1952. What you're also seeing is an increase in the proportion of people in prison. An increase in the proportion of people in prison who are receiving psychiatric medication. So what you're actually starting to see is very tempting to conclude that the prisons are now holding people who once would have been more effectively cared for in psychiatric hospitals. In terms of who you're likely to see, something like 1 in 5 mental health nursing posts are currently vacant. Of course, it depends on which part of the country you're looking at. In some parts of the country, mental health vacancies are relatively okay. In other parts, it's even worse than 1 in 5. And one of the responses to that has been increasing use of nursing associates. Just as with physician associates, what we see is somebody who has had a reduced training, effectively recreating the enrolled nurse, but somewhat differently. So whereas the enrolled nurse would have trained for 2 years full time, nursing associates typically are working as healthcare assistants and doing assessments along the way. So rather more analogous to the enrolled nurses by experience, which was another type of grade that we saw in the past. And usually that took a great deal of experience before you became an enrolled nurse by experience. By contrast, now you can see someone who's a healthcare assistant for a couple of years, can jump through some hoops and eventually become a nursing associate and carry out many of the jobs that were previously done by registered nurses. What you don't see is an improvement in the scope of nursing practice. So you've got mental health nurses now who go through a 3-year course, but aren't necessarily equipped to offer talking therapies. I trained back in 1979, and during the course of my training, I, for example, would have been supervised by a clinical psychologist to treat people with phobias, for example, using behavioral techniques. That's now longer, hardly ever part of the training of mental health nurses. So one wonders, what the value of the move away from an apprenticeship type system, which was full-time, had a lot of experience, but didn't have necessarily the academic qualification. Well, what you're now seeing is they're not getting the experience or the academic qualification because that too has been reduced. So I also want to just mention the proportion of referrals. So numbers of people referred to mental health services in 2023 was around 5 million referrals, which was a 33% increase over 2019. So what we're seeing is increasing referrals, increasingly being treated by the wrong people and in the wrong places. So prisons, A&Es, and so on, which are very poor facilities for treating people who are acutely ill. And what you then end up seeing is things like the crisis team is the kind of gateway to any kind of psychiatric service whatsoever. And their explicit raison d'etre is to keep people out of hospital, not least of which because there aren't the hospital beds available. Now, I'm not suggesting for one moment that inpatient psychiatric facilities are the optimum place to treat people. It's important when people are in a period of crisis, when they're actively psychotic, when they're in danger of harming themselves or others. But the difficulty is now, because the availability of facilities are so restricted, that what one tends to see is that you have to be detained compulsorily. You have to be sectioned to get any kind of treatment whatsoever. Now, of course, 90% of treatment is actually treated in primary healthcare. So typically a person going to see their GP because they're anxious or depressed or whatever else. What's lacking is the ability to refer people on to talking therapies, without which all you're really left with is antidepressants or other psychoactive medication. And I'm not opposing those. I'm just simply saying that whilst they are for some people effective, for others psychotherapy is more effective, and for others still medication may well work. Psychotherapy works, and usually the two work better than either one on their own. So that's really what I wanted to get across. And I'll leave you with this sort of touching little story about the private finance initiative. In Middlesbrough, I was a research fellow in mental health at the transition from St Luke's Hospital, a big old Edwardian asylum, to the new Rosebery Park Hospital. Within less than 20 years of the private finance initiative funded Rosebery Park Hospital being built, large sections of it are now having to be rebuilt. Why? Because as a commercial operation, the contractors built some of the buildings to full specification because those were the ones that they were expecting would be inspected and would therefore be signed off in terms of continuing the contract. But others were not built to the specification at all. And so within less than 20 years are having to be rebuilt. So not only is it an expensive system, but it's a system which has effectively led to poorer quality of facilities being built than would have been built had they been state funded properly in the first place. So it's a false economy and costing an absolute fortune even today. That's it.
Thank you very much, Ian. Another very depressing picture that you're painting there. We now need to go on to our final speaker, which is Mike Hope. Mike Hope is a retired social worker and is at the moment managing brain injury cases. So we're going over to Mike now to look more at the social care aspect of what we're discussing this evening. Mike, over to you.
Not so much a retired social worker, Carol, as somebody who got out of social work. And I'm very pleased that I did, really, because it's a profession which has sadly nosedived. How long have I got, by the way?
10 minutes, please, Mike.
Okay, right. Very quickly, what I'm going to be talking about is primarily adults of working age and older people. I'm not going to be talking about children's social care. That was separated by Alan Milburn, if you remember him, from adult social care in 2002. And I'm not going to be talking about mental health social work because it primarily comes under the NHS. And I think Ian would probably have a great deal more knowledge and experience of that than I do. But social care comes from quite a different place, really. to the health service and the NHS. The origins of what we now call social care are actually in the Poor Law. They actually go back to the original Poor Law was in 1601, under Good Queen Bess. And it was updated in 1834 with an emerging industrial working class. But it was to manage people who were unable to manage themselves, who were poor or who got into difficulty, or in any way were not able to completely cope with life as it was. And that certainly included unmarried mothers. And they were put in workhouses. There were 600 local boards around the country. So ironically, there was a localism there, but it was actually run by the local squires in a very kind of authoritarian way, in a very punitive way. The workhouses were detested and hated because of this punitive approach. They were set up to deter idleness. So right from the very start, we have something within the strand of these public services, certainly, and I would argue many others, certainly the benefit system, which is what we now know as the hostile environment. There has been a hostile environment to poor people or people who in some way or another couldn't cope with the system. But people under the Poor Law were clothed and fed grudgingly, dreadful food, but had to work really hard and were the butt of every local prejudice going. And you know, the whipping boys of the nobility and the monarchy as well. And this strand actually, even though the Poor Law itself, I'll go through how that's been replaced. But the whole question of the punishment of single mothers has carried on really until the 60s or so. I actually, when one of my early jobs in what was then called a mental handicap hospital where I worked, I encountered a woman who seemed perfectly fine, and I inquired of her why she was there. I had a baby. That was all. She'd had to spend a lifetime. She was in her 50s. She'd had to spend a lifetime in this large, very institutionalized setting. But also, the children, even until quite recent time, were sent to places like Australia or out generally to the colonies. So that is the legacy of the Poor Law. And that really carried on until the Local Government Act of 1929. That abolished workhouses in principle, though actually many of them carried on as hospitals and were always locally feared. But local authorities took on responsibility for administering the updated Poor Law. And they also took on infirmaries and fever hospitals and so on. So that is why there's never been a very clear divide between health and social care. Some institutions which we have thought of as hospitals actually do have their origins in the Poor Law. But I mean, it was something which it was clear that it was not possible to manage in a modern setting with this updated Poor Law. So in the post-war period, as the NHS was being set up, alongside of it, but quite separately, there was the National Assistance Act of 1948. And that established residential care for older people and younger people with disabilities. the ability to register and inspect the charitable homes, which are some of the, really quite places with bad practices, which went back really quite a long way back into the poor law, but also to establish things like day centres, set up things like Meals and Wheels. And at the same time, really, social work was established as a profession. Social workers had existed as sort of people who worked amongst the poor in so-called settlements. It was a bit like they were going out and sort of, the idea of colonizing the unknown land of the poor. That is where social workers actually came in. But there was genuine philanthropy involved in it, but it was, I think, it was always very paternalistic. But social workers then were set up as a profession after the National Assistance Act, and we had accreditation. The degree didn't actually come in until the 1990s. So under the National Assistance Act, people actually, they were treated in a hierarchy. They were treated without respect. Their views were not sought as to what they thought they needed. But these things in the post-war period were relatively well funded. And we then had, at the beginning of the 70s, there was a particular Labour politician, Alf Morris, who pushed for what became the Chronically Sick and Disabled Persons Act of 1970. And that really provided for a range of care and welfare, access for people with disabilities, and the idea that wherever possible, what people got should be based upon their perceived need, always as assessed by the experts, not by the people, but their perceived need rather than available resources. And in the end, that is why the Chronically Sick and Disabled Persons Act had to be gotten rid of, because there were test cases in the 90s where local authorities were told that they couldn't deny a person services under the Act because they didn't have the money. That was not a reasonable excuse. So obviously, that legislation had to go, was no longer fit for purpose for a set of governments, Thatcher and who followed, Thatcher, Major, and then, as we've heard, New Labour, who were, determined to make sure that the state did not have the prime responsibility and that these things were outsourced. The whole process of outsourcing started with the fabled care in the community approach. Thatcher and Major, the late 80s, early 90s. Closure of lots of long-stay mental health hospitals, mental handicap hospitals, under the guise that people would live in the community and live far more normal lives. However, it was always done on the cheap. And seaside towns know full well that the epidemic of mental health issues which followed was because people were just taken from long-stay hospitals and put in the hands of local landlords and landladies, and they didn't have the community backup to really support them. And there was also a closure of a lot of NHS nursing homes and places where people recovered after having been seriously ill. They were transferred to local authorities, but at the same time, local authorities were being more and more starved of cash. So while local authority had these residential institutions, they were put in a position where they had to privatize them. And that happened more and more also to the council home care services, that is, the services delivered by care staff to people in their homes. That was
You've had 10 minutes, so if you could be
okay. That was no longer really made possible, and in the privatization, initially it might have been smaller local businesses, but these businesses were very quickly gobbled up by large corporate interests, and the whole question of eligibility criteria came in, so that it wasn't so easily possible for people to get help. So there had to be, in essence, more and more sick, more and more disabled, more and more unable to cope with everyday life before there was any chance that they would have any help at all. The only NHS service remaining in the community was continuing healthcare, which has been always a massive struggle for people to get. So now we have care providers who are these large corporates, hedge funds, private equity companies, based on a model of profit extraction, highly leveraged, then they go bust. Southern Cross went bust. They ran 750 care homes in the UK. Also scandals, Panorama, typically sort of exposing abuse by acting undercover. Companies like Castlebeck, again, a very large provider. So really, within the private care home sector has become, almost Dickensian in its disgrace. Care agencies in the community, private, very low wages, scarcely the living wage. And again, the private care providers have been bought out by the corporates. Staff having little or no training. As I say, the minimum wage, if that, not being paid for travel time between cases. Told that they have no skill when there is massive skill in looking after, let's say, somebody with dementia. And on the other hand, very hard because of their fragmentation to unionize. But Unison, the GMB have made some progress, and also some of the smaller pop-up unions like the IWGB and the IVW have managed to unionize some of these care workers. We currently have a shortage of home care staff, 165,000 shortfall, because of the massive low wages. Most indigenous workers will not work for that sort of money. So there's been pressure to bring in care staff from abroad, and we've heard some of the pleas for exceptions. But there has been a scandal of recruitment agencies promising secure paid jobs to people from countries in Africa, India, Philippines, and then giving them not the work they were promised, minimal work, not the wages they were promised, having to work unpaid, having to pay extortionate charges for their own food and accommodation, which of course was provided by the agencies. And then to cap it all, you have the Crown acting in conjunction with these rip-off agencies in a sort of people trafficking operation. The Home Office is contacted by the agencies, and then they come in to deport those people who don't have the jobs that they were expecting. So, I mean, the whole private care provision is actually a situation of the Wild West. What we need, very simply, I mean, there's the Zoom meeting tomorrow, which people have been invited to join, you will hear some of the demands. That there is a national care and supported living service which is provided free at the point of use, like the NHS. That has never been the case until now. Well-trained and well-paid and trained staff with a career progression, the voices and the needs of those receiving care listened to and incorporated. That more than there's a term co-production, but actually we need genuine democracy, not anything which is top down. So in essence, that's it. Do come and join the meeting tomorrow, and then you will hear how this campaign is putting its demands to the various political parties, and it'll be really interesting.
Thank you very much. Thank you very much, Mike. I think all three of our speakers have painted a pretty grim picture of health and social care in this country. Of course, what are we going to do to reverse this situation? We can't rely, we know the Tories won't do it. They brought us to this place. Unfortunately, we know we can't rely on Labour either. They are wedded to the American-style healthcare company models. They're paid by lobbyists to support it. So what we believe in our group is that we need a radical political change. And that radical political change will include a written constitution where healthcare and social care will be guaranteed for all citizens, free at the point of use. We believe that democracy must come from below, with citizens' assemblies, local assemblies, regional assemblies, where people will have real power in their local communities to enact change. So this is what we believe is needed, a radical change, a radical political change. I see Steve's got his hand up, so I'm going over to Steve now.
Thank you, Carol, and thank you all the speakers. Really informative, and I think I think in some ways the NHS is almost like the story of the. Let's mute myself. I'm muted. There we go. In some ways, the NHS is almost like the story of the post-war welfare state. You know, the rise of the welfare state and the decline. It follows that whole pattern. And I think if a system goes into decline, which it did, as has been outlined by all the speakers, from the neoliberal reforms beginning with Thatcher, carrying on by Blair. But if it continues to go downhill, as it were, it comes a point where it just doesn't function at all. And I think, this is what I think I've taken from all the different parts don't work, and any bit that's at a state, you reach a state of total system failure. Now, total system failure was what Dominic Cummings said about the NHS after the pandemic. But I think he had a point that nothing really worked effectively because everything undermines everything else that's taking place. And so in a way, you need a kind of a radical change. There's no way in which the system can be reformed. And democracy, it seems to me, is central to how we might do that. So I think that our argument, I guess, and the one that Carol says, is you can't make the health service work on its own if you don't make the whole political system work, because it's that political system that's tied in with the American private model. And that's the thing that we've got. And I suppose we don't need to look to America. We can look at our own social care system to see how it has actually failed. So anyway, I think I'll let other comrades come in and maybe we'll see.
Thank you, Steve. I'm bringing in Peter Grant.
Thanks, Carol. Can you hear me?
You can, loud and clear.
Great progress. Yeah, I think the contribution from Dr. Bob Gill really worrying and frightening, to be honest, because I never heard anyone actually lay it out as as bare as that, what is actually going on in the service at the moment, and especially the penetration of private capital and these American bandit companies that have ripped off the Americans for years and years and now want to rip us off, and the corruption that was evident during the pandemic, where let's not bandy around too many names, but Baroness Moan is one of them. The most famous, I think, is probably her title. Has grabbed herself millions of pounds out of the health service budget, and it's these things are an absolute disgrace, and they do make people very, very angry. And if you've been unfortunate enough to have to cope with the health service at the moment, you will you know full well the consequences of all of this. That we unfortunately, my wife Elizabeth suffers from a hypoxic brain injury, and we've been in and out of all the hospitals in the northwest. We have a special travel card and reserved seats, but the way that the nursing staff and the doctors and the other medics working in these hospitals are working miracles to keep the thing going. I mean, by rights, it should have actually completely collapsed by now. But they're treating people, we've spent, the worst we spent was 2.5 hours in the back of an ambulance outside Preston Hospital before we could get in to Preston Hospital. And we ended up in the facilities there in basically what was a broom cupboard, because they hadn't got anywhere else to stick Liz. And she spent all her time, nearly 3 weeks in there, on an A&E trolley. That's not a bed, that's an A&E trolley. It's a different thing to a bed. And that's all right, Liz, I'm not... No! And you cannot treat people like that. It's impossible to actually do the job properly and with respect and everything that you're entitled to. And the other thing is that when you talk about continuing healthcare, I'm lucky. I actually managed, God knows how, but I actually managed to secure continuing healthcare. And it's a big difference, because it is the National Health that's paying for it. And we've got carers now coming in after 4 years of me struggling, trying to, look after Liz as best I can. We've now got carers coming in, and it's lifted a massive weight off me, and it's helping Liz. But the thing is, this company, Alcedo Care, is supposed to be the best in the northwest. They're charging the National Health Service for the carers just under £50 an hour, because they've had to go for training on the hypoxic brain injury. That training, incidentally, was a couple of hours in the manager's office. So, when they say they've done some training, I mean, that doesn't sound like training to me. But they're paying the National Health. They're charging National Health Service just under £50 an hour. The carers get £13 an hour, and I've mentioned it to them, and they've been absolutely shocked at what's going. They thought it was normal, £13 an hour. So that's the that's the ripping off that's going on. And the other thing I'd like to mention, which was brought up, is mental health services, because when all that goes wrong, and the people don't get the help that they should get, then you get people killed, like the people were killed in Nottingham, the people that were killed in London, etc., etc. And also the people that I was had to be involved with, unfortunately, who jumped in front of my train because they were at the end of their tether and they wanted to end their life, and they thought the train was the best way of doing it, because the gas ovens don't work so efficiently so much now, with the the old town gas where people used to use that. So it's impacting other parts of society, other professions, as well as the health service. When you look at it that way, that it's driving people onto the railway to commit suicide, and it happens day after day. If you hear on the announcement there's been an incident and trains have been cancelled, that's what it is. Somebody has gone underneath a train. That's what's happened when they make that announcement. So thank you very much, Dr. Bob Gill, and the rest of the speakers. It's been an excellent meeting, and it's got stuff for me to think about and to take away. So thank you very much.
Thank you very much, Peter, and thank you for sharing your own personal situation. It really, a personal story really brings this home to people. So thank you for doing that. I don't see any other hands up now. Oh, Steve, we've got Steve, and then I'll go back to our speakers. Steve.
I'm not going to make another contribution particularly. I just really want to ask Bob and the other speakers, how do they think? Because what they've outlined to us, and it's a story we're aware of, but the details are always more illuminating and enlightening and in many ways worse than we thought. That's it. And obviously, public education is what we're trying to do. But how does Bob or the other comrades think we might be able to fight against this? Because obviously, campaigning is one thing, but what do they feel we can do to fight back against this? Because in a way, the NHS is rather like a brand. It's like as if it's got nothing inside it. It's a name which is very powerful as a name because it's loved really by the people. People love the idea of it, which is why they have such a difficulty in getting rid of it. So it's loved by the people. Eventually, the people will become disillusioned with it because of what they've done. So I don't know how do the comrades, the speakers, think we might be able to fight back in the next period after we had Starmer and his gang in power.
Yeah, that's very important indeed. Can I go to you, Dr. Gill, to come in here and give your contribution, answer to that question?
Yeah, so in terms of education, I think given the performance of our governments in recent years, trust is at an absolute low. Also, people's trust in media, mainstream media, is reduced. So there's an opportunity for independent media to develop, to get this message out, to get the education process going. So that has to be first. We also need to look at our organizations that are supposedly we pay to defend our interests, such as our unions and our professional bodies. And the more people start looking up within their organizations to say, hang on, what are you guys actually doing? And why are you spending no effort informing us of what's going on? In fact, it's worse than that. They're actively colluding to achieve the government's ends. So, there is something called the Social Partnership Forum struck up between government, the unions, the health unions, and the Royal Colleges, essentially to do nothing to stop this program. But there's close to zero awareness of the members of these organizations that is the case. So it would explain a lot. It would explain why the unions are so quiet and their messaging just dovetails what the government is saying about more funding. So yes, I think we need to hold our union leaders and shop stewards and all the rest of it to account, organize ourselves in terms of informing colleagues and other are the members of these organizations that we pay to defend us. There's no excuse. Otherwise, what's the point of a union? So, that would be my starting point. Independent media, public awareness, pressure on the unions. And there's a lot of activity on social media, which has massively raised this whole doctor substitution agenda to another level. So within a few days of the anaesthetists saying they're going to crowdfund a legal case, they raised £50,000. So there is an appetite amongst the public and the profession for genuine people to step up and represent us. There is just a capture at the top, which we need to break through. And, I wish all the independents who are standing in the forthcoming election the best of luck. We have to break this two-party paradigm, first past the post situation. Otherwise, it's a constant uphill struggle. And we need to dissect our media from its entanglement with government. Their duty is to hold power to account and not to collude and keep us in the dark.
Absolutely, Dr. Gill. Absolutely. I'm going to bring in Mike as well now. Thanks very much. I'm going to bring Mike in.
Yeah, I think I agree with everything that you've said, Bob. I think that with regard to integrated care systems, which were designed very specifically to hold budgets down, there is no budgetary flexibility in them at all. I have some case experience of dealing with them, and they just become utterly unreasonable. But we find that Unison certainly was quite positive about integrated care systems when they were first introduced. We find that my own union, Unite, has a very muddled approach towards them and doesn't really, frankly, understand what they are about. We do have Keep Our NHS Public, which has managed to raise quite a lot. We also have other campaigns. There's more of a patient-led campaign called Just Treatment. And there's also We Own It. What comes out is that actually, I think this is in relation to the work that We Own It does, which is across all public services or ex-public services, there is a real appetite amongst a majority of the British public to renationalise. And, to that extent, the people are well ahead of the politicians. Now, that should come as, well, no surprise to the Tories, because they are determined against all evidence to go in the opposite direction, purely because it enriches their friends and of their ideological zeal for the small state approach. But with regard to Labour, we have Wes Streeting saying that he has a role for the private sector. Echoing your words, Bob, what Wes Streeting also has claimed it's to help the NHS recover after the pandemic. And like you say, you go down the private road and it never will. So I think there is an appetite. We do need the leadership. At the moment, it's coming from some of these campaigns rather than from union leaders. But I think, and in social care, that's the other thing to say. From social care, it's much less understood, and it's only when people become have personal experience from the family member that they begin to see what a dreadful collapsed system it is. When you talk to Labour candidates about social care, they shrug and go, "Huh, never comes up on the doorstep." Well, actually, that is beginning to change. But the social care coming from a different place than the NHS is far less understood. And why it is as it is, really, we need to spell it out in 10-foot high letters. So that can be part of our job.
Absolutely, Mike. I don't see any more hands up now. So I'm just going to add the spotlight and to Dr. Gill. Thank you both very much for coming and speaking to us this evening. It's been, as I said before, you've painted a pretty grim picture of where our future lies with regards to health and social care in the UK. And I hope that with meetings like this and other educational meetings, I know, Dr. Bob, you've done so much work on this and been on the Not the Andrew Marr show, goodness knows how many times, getting this message across to people. And Mike's got a very important meeting tomorrow, which we're all encouraged to go to, tackling social care, the extremely bad situation we have with social care. Just thank you very much indeed for coming along, leading the discussion and telling us how things are and how things might be better.